بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد أشرف خلق الله أجمعين. My great pleasure today to introduce this outstanding scientific presentation about intrathecal morphine, which is very interesting topic, which passes a very long journey. What for? Why not? Every details you want to know. Of course, our great Prof, Dr. Mohamed Ahmed, will clarify every details and every point for you in his valuable scientific presentation today, which mainly based upon his valuable and highly experience. It is a great pleasure today to introduce my great Prof as a moderator of this scientific presentation, my great Prof and my great mentor, Dr. Yasser Zaghloul. And many thanks for you, sir, for your unlimited and outstanding support for MEC. Yes, it's yours, Dr. Yasser.
اوكي، شكرا جزيلا دكتوره صفاء. يعني اسمحوا لي ابدا الاول كلمتين باللغه العربيه وبعد كده نكمل بالانجليزي ان شاء الله. طبعا انا هقول يسعدني ويشرفني اقدم اخي وصديقي وحبيبي العزيز محمد احمد. اشتغلت معاه يمكن فتره قصيره في النيابه في بدايه التدريب بتاعه، التدريب عنده في جامعه اسكندريه، لكن كان وما زال له منزله خاصه عندي، ويعني أشهدكم إني أحبه في الله. Now we are coming to our Menoufia Anaesthesia club, and Dr. Mohamed Ahmed, he will talk about the intrathecal morphine in the perioperative setting, the unresolved controversies. Dr. Mohamed Ahmed is former associate professor of anesthesia in Alexandria University in Egypt, and currently he is a consultant anesthesiologist in King Fahd Specialist Hospital in Dammam in Saudi Arabia. And I am sure you will enjoy his lecture. I saw him in the lecture, 2 lectures before, one of them traumatic brain injury. It was very fantastic, and he can explore any anesthetic problem very well. Welcome, Dr. Mohamed Ahmed.
Thank you, Dr. Yasser, very much, and thank you for Dr. Safa for this nice introduction. And for the sake of time, I will start the presentation. Today, our presentation will be about the intrathecal morphine in the perioperative settings, the unresolved controversies. In this presentation, we'll pass through a brief introduction about the issue of the intrathecal morphine, followed by the pharmacology of the morphine and in particular the intrathecal route, and then the evidence that support the use of intrathecal morphine. And then we will go through the recommended doses and the adverse effects of the intrathecal morphine. And at the end, we will go to the recommendation for using intrathecal morphine. Why we are talking about intrathecal morphine? Because intrathecal injection is a very simple technique for any anesthesiologist. It is quick. It doesn't take too much time. Failure rate of intrathecal injection is very low for any anesthesiologist, whatever he is senior or junior anesthesiologist. There is low incidence for technical complication resulting from the intrathecal injection. And intrathecal morphine provides effective analgesia. And of course, we are talking about the preservative-free intrathecal morphine. There was a trend for increasing use of the intrathecal morphine in the perioperative settings. And these studies that was published in the World Journal of Surgery in 2009, they observed a change in the practice from epidural to intrathecal morphine analgesia for hepatopancreatic biliary surgery. In their hospital, they introduced the intrathecal morphine at 2006. They did a study for reviewing all patients who did hepatopancreatic biliary surgery over 4 years from 2005 until 2008. And they audited the method of analgesia. And they found that there was an increasing trend for use of intrathecal morphine on the expense of decreasing the incidence of use of thoracic epidural analgesia. And at the end of these studies, they concluded that in resource-limited settings, intrathecal morphine compared with thoracic epidural analgesia is associated with reduced incidence of post-operative hypotension, reduced requirement for intravenous fluids post-operatively, and shorter hospital stay and lower incidence of respiratory complications by the use of the intrathecal morphine. If we will go back in the history of the use of intrathecal morphine, we will find that intrathecal morphine started to be used maybe more than 120 years ago, when one Romanian surgeon used intrathecal morphine injection to treat perioperative pain. After that, the intrathecal morphine continued to be used, but not on a systematic base, and until early 70s of the last century, when the mechanism of action of opioid was recognized by the discovery of opioid receptors. And in 1977, it was proved that opioid receptors are available in the spinal cord. And this discovery gave people more rationale to use intrathecal injection of morphine, because they are injecting morphine nearby the site of action, which is the opioid receptors in the spinal cord. And the first published study on perioperative or the use of intrathecal morphine to relieve pain was published in Anesthesiology journal in 1979, when Wang et al. Used intrathecal morphine to treat 8 patients suffering from advanced genitourinary cancer. These 8 patients had intractable severe pain that was not relieved by large doses of systemic opioids. After approval of the patient and approval of the ethics committee, they injected these 8 patients with 500 to 1,000 mic of intrathecal morphine. And they found that after 45 minutes, 15 to 45 minutes after the injection, all the patients injected with intrathecal morphine experienced complete relief of pain, and patient remained pain-free for 12 to 24 hours after the intrathecal injection of morphine. And in these 8 patients, no one developed sedation and no one developed respiratory depression. This study encouraged a lot of anesthesiologists to use the intrathecal morphine in the perioperative settings. What is the mechanism of action of intrathecal morphine? As we all know, that opioids in general do their action by stimulation of the opioid receptors. We know that we have 3 main opioid receptors: mu, delta, and kappa receptors. The one which is of most interest for us is the mu receptors, because through mu receptors, opioids produces the analgesic effect. And also through mu receptors, opioid produces the side effects and unwanted effects like sedation, vomiting, respiratory depression, pruritus, anorexia, urine retention, and also physical dependence. If we see the site of the location of opioid receptors, we will find that mu opioid receptors is present in the brain, also in the spinal cord, in the chemoreceptors, in the CNS and the peripheral nervous system, and through the action on the chemoreceptors, the opioids will produce respiratory depression. Mu receptors are more concentrated in the basal ganglia in the brain, and in the spinal cord, mu receptors is located in the dorsal horn of the spinal cord. And when the opioid agonists will act on the mu receptors of the spinal cord, it will lead to inhibition of the release of glutamate, and this will cut the transmission of pain stimuli in the spinal cord. One of the major side effects of intrathecal opioid is respiratory depression, and in case of morphine is delayed respiratory depression. The mechanism of respiratory depression produced by opioids is through the action on the chemoreceptors present in or located in the CNS and the peripheral nervous system. Opioids make these chemoreceptors insensitive to the increasing level of CO2 in the blood. So when the CO2 is rising in the arterial blood, there will be no increase in the ventilation. So patient will remain hypoventilated, although the CO2 is rising in the blood. This is the mechanism of respiratory depression produced by opioids. If we will talk about the intrathecal morphine pharmacokinetics, after we inject any opioid in the CSF intrathecally, this opioid will be distributed through the CSF upward towards the brain, and the opioid will be diffused into the spinal cord and it will diffuse into the brain. Also, some of the opioid injected in the CSF will diffuse into the epidural space and will be absorbed by the epidural fat, and opioids will be released from these tissues by vascular reuptake. In case of morphine specifically, we know that morphine is hydrophilic, so it will remain for a longer time in the CSF intrathecally, and the diffusion into the epidural fat and reuptake by blood vessels will be very slow. This will give long duration for the analgesic effect of morphine. And also it will be responsible for the delayed respiratory depression noticed in case of intrathecal morphine. The diffusion of the morphine into the spinal cord and into the brain tissue is also slow, and this explains the slow onset. If we will inject morphine intrathecally, we will wait for 45 to 1 hour for analgesic effect to start. This is due to the slow diffusion of morphine into the brain tissue and into the spinal cord. All this because morphine is hydrophilic. It is less lipid soluble than other opioids like fentanyl, sofentanil, and alfentanil. Now, what is the evidence that leads us to use morphine intrathecally? We will pass by a sample of the studies that used intrathecal morphine, and we will see the effect of intrathecal morphine reported in these studies. The first study came from the Prostate Cancer and Prostatic Disease Journal. This study was published in 2002, and they used intrathecal morphine for cases undergoing radical prostatectomy. We all know that radical prostatectomy is a major surgery, and patients mostly are elderly patients. They did a retrospective study on 62 patients, and those patients who received intrathecal morphine, they received a dose between 200 mic to 500 mic. And the post-operative analgesia was maintained by the use of IV ketorolac. And they found that out of these 62 patients, there was 28 patients who didn't need any opioid post-operatively until the patient was discharged from the hospital. And the remaining 34 patients, they required an average dose of 13 milligram morphine. And of course, this dose of morphine is a very small dose to be used for post-operative analgesia in such major surgery. And they concluded that the use of intrathecal single preoperative injection of intrathecal morphine combined with IV ketorolac resulted into effective analgesia, diminished supplemental narcotic requirement, and high patient satisfaction during radical prostatectomy. Another study that was published in British Medical Journal in 2019, they compared the use of intrathecal morphine to the epidural analgesia in patients undergoing laparotomy for gynecological malignancy. And the patients, they included 80 patients in this study. The IT intrathecal morphine group received single dose of 200 mic preservative-free morphine plus 75 mic clonidine and 15 milligram bupivacaine. And post-operatively, analgesia was maintained by diclofenac, paracetamol, and weak opioid oxycodone to 10 to 20 milligram twice daily. And the other group received epidural analgesia, a mixture of bupivacaine 0.1% plus adrenaline 2 mic per ml plus fentanyl 2 mic per ml. And any patient who was suffering from pain in either groups, these groups, although the maintenance of the post-operative analgesia, they will give rescue opioid of 0.5 to 1 milligram morphine. What they found that the intrathecal morphine group used less opioids in the first week post-operatively compared to the epidural morphine group. And they didn't report any serious adverse events in either intrathecal or epidural analgesia group. Regarding the hospital length of stay in this study, they reported that the intrathecal morphine group has significantly shorter hospital length of stay compared to the epidural analgesia. And there was no difference in the quality of analgesia. Intrathecal morphine was as compared to the epidural analgesia. And they concluded that intrathecal morphine is more simple to administer, more simple to manage than the epidural, and it produces analgesia, which is comparable to the epidural analgesia in these cases, and it decreases the hospital length of stay. In cabbage surgery, this study was published in Anesthesiology in 2004, and they assessed the use of neuroaxial opioids, both intrathecal morphine and epidural opioids in cabbage surgery. And they found that if we will use neuroaxial opioids, this will not add to the morbidity or mortality after cabbage surgery. And neuroaxial opioid, either intrathecal or epidural, will lead to a faster time until tracheal extubation in these patients. These are samples of the doses that was included in this study. They used in one trial 500 mic intrathecal morphine. In another trial, they used a very high dose intrathecal morphine, 2,000 and 4,000 mic. And in another trial, they used the sufentanil 50 mic in addition to 500 mic intrathecal morphine. And in another one, they used 20 mic per kg. These doses are very high for the use to be used for the intrathecal route. In another study, they compared the addition of clonidine in CABG surgery to the intrathecal morphine, and they found that when they add 75 mic clonidine to 4 mic per kg intrathecal morphine, they found that this addition will lead to earlier extubation and better analgesia following CABG surgery. This study was published in the Journal of International Medical Research in 2016, and they studied the efficacy of intrathecal morphine following open nephrectomy. And the study included 45 patients, 23 of them intrathecal morphine was injected in a dose of 300 mic, followed by IV PCA. The remaining patients, the remaining of the 45 patients, they received general anesthesia without intrathecal morphine and followed by IV PCA. They found that pain was less in the intrathecal morphine group. The consumption of morphine in the following 72 hours after surgery was significantly lower in the intrathecal morphine group, and opioid-related complications and side effects were similar in both groups. In another study, they compared the intrathecal morphine to the extended release epidural morphine in pediatric patients undergoing scoliosis surgery. Dose of intrathecal morphine in this study was 77.5 mic per kg, and the extended release epidural morphine dose was 150 mic per kg. And they found that the both intrathecal morphine and extended release epidural morphine produced adequate comparable analgesia in the first 24 hours after surgery. And then for another 12 hours, from 24 hours to 60 to 36 hours, the analgesia was more potent in the extended release epidural morphine group, and all the side effects were comparable in the both groups, except the incidence of pruritus, which was higher in the intrathecal morphine group. This is a literature review that was published in 2019 in Anesthesia Pain Medicine. They studied the intrathecal morphine for major hepatopancreatic biliary surgery. They included studies from 8 countries, from USA, from South Korea, from UK, from Iran, France, Italy, Australia, Canada, and New Zealand. The literature review included 663 patients who did the hepatopancreatic biliary surgery. The doses of the intrathecal morphine ranged from 500 mic, and the lowest dose was only 200 mic. And they found that when they used intrathecal morphine, they found that, and they concluded that single shot of intrathecal morphine may be more appropriate than epidural analgesia as a first-line analgesic technique for major open hepatopancreatic biliary surgery. And although the intrathecal group utilized more opioid post-operatively, but the analgesia was adequate in this group. The intrathecal morphine group required less fluids in the post-operative period. And we know that this is very important in this kind of surgery because if we give more fluids in the post-operative period, it will increase the edema at the anastomotic site, and it will cause the gut edema, and it will delay the intestinal movements. It will increase the incidence of leakage from the anastomotic site. So there is a lot of complications if we will give more fluids in this kind of surgery in the post-operative period. Also, they found that the intrathecal morphine group have a shorter hospital length of stay. In another study came from Australia, they assessed the use of intrathecal morphine in cases of liver resection, and they used a dose of intrathecal morphine ranging from 150 mic to 500 mic. And this study included 216 adult patients. And they excluded the patients who received epidural analgesia. Usually we don't like to put epidural catheter in patients who are undergoing hepatic resection for fear of the coagulopathy that develops after the hepatic resection. So patients received intrathecal morphine and general anesthesia. And they concluded that the intrathecal morphine combined with conventional multimodal analgesic strategies reduced the opioid requirement and improved the analgesia for the 24 hours following surgery. And they didn't report an increased or significantly increased incidence of respiratory depression or other complications of the intrathecal morphine. But in these studies, they reported that the cost of the health care in these cases was increased in the intrathecal morphine group because all patients who received intrathecal morphine has to be admitted to the ICU for 24 hours after surgery. What are the recommended doses and what are the side effects of intrathecal morphine? In this tutorial that was published by the World Federation of Societies of Anesthesiologists in 2017, they published this guide for dose recommendation of intrathecal morphine. Of course, they said that it is contraindicated to use intrathecal morphine in day case surgery because of the fear of the development of late or delayed respiratory depression. So we cannot use intrathecal morphine in day case surgeries. In hip and knee surgery, the range was 100 to 200 mic. In the CS, the range of intrathecal morphine was between 100 to 150. TURP cases needs a very small dose of intrathecal morphine, only 50 mic. And major urology surgery needs from 100 to 300 mic according to the extensiveness of the surgery. But major laparotomy will need a high dose that can reach up to 7 to 10 mic per kg. They do not recommend to use intrathecal morphine in thoracotomy as a first line of analgesic technique because many of the studies proved that intrathecal morphine is more effective in laparotomies than in thoracotomies. But if we will use intrathecal morphine in thoracotomy, we may need to a dose as high as 10 mic per kg. And for the spinal surgery, they recommended a dose of 3 to 5 mic per kg. And in this tutorial, they mentioned that patients who will undergo major laparotomies like major hepatic surgery and Whipple, they will need a higher dose than the 300 mic limit that was recommended by many authors. They said that if we will give this patient only 300 mic intrathecal morphine, the analgesia will not be as good as using a higher dose like 7 to 10 mic. The problem is that if we will use intrathecal morphine in an ineffective dose, we have to use the parenteral opioids, and the combination of parenteral opioids and intrathecal opioids puts the patient at higher risk to develop respiratory depression and other side effects of opioids. In this review article that was published in Pain Research and Treatment Journal in 2012, they also published a guide for the dosage of intrathecal morphine. And as the previous guide, TURP needs only 50 mic, cesarean section needs 100, hip replacement needs 100 mic, and knee replacement needs 200 mic of intrathecal morphine. But abdominal hysterectomy needs a higher dose, 200 mic. Abdominal colonic surgery needs 300 mic. Spine fusion and scoliosis needs 400 mic. Thoracotomies needs 500 mic. And extensive laparotomy like abdominal aortic surgery and for cardiac surgery, they recommend to use 7 to 10 mic per kg. This is an important review article. It is a meta-analysis published in 2009 in Anesthesia Journal about the risks and side effects of intrathecal morphine combined with spinal anesthesia. In this meta-analysis, they included 790 patients in the intrathecal morphine group and 524 patients who received placebo. And the analysis of these cases, they found that, according to this meta-analysis, there was no agreement about the definition of respiratory depression, because some studies put a limit of respiratory rate of 12 as an indication for respiratory depression, others put a limit of 10, and other studies put a limit of 8 breaths per minute as an indication of respiratory depression. But the overall conclusion, according to this meta-analysis, they found that no increase in the risk of the respiratory depression compared to placebo. So the overall intrathecal morphine didn't increase the risk of respiratory depression compared to placebo, because placebo used the other opioids by other ways, systemic opioids. But there was very important and significant observation. They observed that all patients who developed respiratory depression, they received a dose of 300 mic or more. And from this meta-analysis, we will find a lot of authors who are recommending that we don't have to exceed 300 mic of intrathecal morphine to decrease the incidence of respiratory depression. But in this meta-analysis also, they said that due to the small number of cases, our analysis does not have sufficient power to decide whether intrathecal morphine increases the risk of respiratory depression or not. And they couldn't recommend to shift from intrathecal to systemic opioids because, according to what they said, also the systemic opioids will produce respiratory depression. In the same year that this study was published, another study was published in the British Journal of Anesthesia, and it was also a meta-analysis, and it included the 27 studies, 645 patients, and they examined the intrathecal morphine without local anesthesia in patients who are undergoing major surgery. And according to this meta-analysis, there was no evidence of linear dose responsiveness for any of the beneficial or harmful outcome of intrathecal morphine. This means that If we will use low dose of intrathecal morphine, this does not guarantee that the patient will not develop respiratory depression or other side effects. And according to this, also, if we will increase the dose of intrathecal morphine, this does not mean that the analgesic effect will go up with the increasing doses. The conclusion of this meta-analysis was that intrathecal morphine decreases pain intensity at rest and on movement up to 24 hours after surgery. And it produces morphine sparing, and according to them, the respiratory depression still remains a major safety concern. According to the tutorial of the World Federation of Societies of Anesthesiologists, that respiratory depression, and more specifically the delayed respiratory depression of intrathecal morphine, remains a major issue. And according to them also, a large meta-analysis of trials of intrathecal morphine showed that those patients at higher risk to develop respiratory depression, but fortunately, according to this meta-analysis, no one of the patients who developed respiratory depression from the intrathecal morphine needed endotracheal intubation or mechanical ventilation. All these patients was managed successfully by the use of the antidote naloxone. And the challenge is how to detect respiratory depression, because if we will depend only on the respiratory rate, we will find that those patients who have slow breaths per minute, they may have deep breaths, large tidal volume, and normal CO2 tension in the blood. So these patients, although they have slow respiratory rate, but they do not suffer from respiratory depression because the CO2 is normal in the blood. And they recommended to use or to do arterial blood gases in the post-operative period during the first 24 hours after injection of the intrathecal morphine to detect these patients who have increasing CO2 tension in the blood, who are at risk to develop more respiratory depression. This is a recent and large meta-analysis that was published in the British Journal of Anesthesia, and it included 2,500 patients who received the intrathecal morphine for abdominal surgery. And in this meta-analysis, they considered the patient who developed respiratory depression is the one who needed either naloxone or ventilation to support the hypoventilation produced by the intrathecal morphine. Any patient who didn't receive naloxone or who didn't receive post-operative ventilation, they considered him that this patient didn't develop respiratory depression. And this meta-analysis included 40 trials, but 2 of these 40 trials used a very high dose of intrathecal morphine. One trial used 15 mic per kg and the other trial used 50 mic per kg. And they found that the incidence of respiratory depression was very high in these 2 trials. When they excluded these 2 trials and they did analysis of the remaining 38 trials, they concluded that the respiratory depression was not increased when the dose of intrathecal morphine was less than 1,000 mic. And also they concluded that intrathecal morphine has several benefits, including reduced systemic opioid consumption, low pain score, and slightly reduced length of stay in the hospital. This is the incidence of expected side effects of intrathecal morphine. The respiratory depression occurs in 7% of patients. Pruritus is the most common and most annoying to the patients. its incidence may be up to 37%. There is no reported incidence of urine retention because most of the patients who are undergoing these major surgeries, usually they have urinary catheter in place. So we cannot judge the incidence of the intrathecal morphine-produced urine retention. And the incidence of nausea and vomiting was as high as 25% or more in the cases. Patients who are at increased risk to develop respiratory depression are elderly patients, and those patients who received higher doses of intrathecal morphine, according to the schools that says increasing the dose will increase the incidence of respiratory depression. And the patients who are receiving concomitant opioid by IV BCA or systemic opioid in addition to the intrathecal morphine. Also, those patients who have a lot of comorbidities, obese patients, and patients who have obstructive sleep apnea, all these patients are at increased risk to develop respiratory depression after the intrathecal morphine. And these patients need more intensive monitoring and observation in the first 24 hours after injection of the intrathecal morphine. What happens and how we manage a case if we inject by mistake large dose of morphine into the intrathecal space? This is a case report that was published in Anesthesiology 2008. A lady, 45 years old, they planned to do exploratory laparotomy for gynecological malignancy. And the plan of analgesia was to do combined spinal epidural. They planned to inject 20 mic fentanyl in the intrathecal space and 7.5 milligram extended release epidural morphine in the epidural space. And during the technique of the combined spinal epidural, by mistake, the anesthesiologist injected the 7.5 milligram extended release epidural morphine into the intrathecal space. So this patient received 7,500 mic of morphine intrathecally. And they observed the patient for 1 hour after the injection of intrathecal morphine. And during this 1 hour, patient was fully conscious and she didn't show any respiratory depression. They decided to proceed for surgery, and they give the patient general anesthesia, but without any additional opioids. And surgery, at the end of surgery, after 6 hours from the injection of the intrathecal morphine, they tried to wake up this patient. And the patient was extubated successfully and shifted to the post-operative post-anesthesia care unit, but the patient was sleepy. They started naloxone infusion, 40 mic per hour, and titrated the dose until it reached 140 mic per hour. At that dose, patient was having sufficient ventilation and acceptable conscious level. They shifted the patient to the HDU, and in the HDU, patient was hemodynamically stable and ventilation was not less than 10 breaths per minute. This was a limit they put for respiratory depression. After 22 hours from the injection of the intrathecal morphine, patients started to complain of pain and they started to give her parenteral opioids. This case report shows that even large dose of intrathecal morphine that was accidentally and by mistake injected can be treated and managed with the antidote naloxone, and they didn't need for post-operative invasive or non-invasive ventilation in this patient. In this review article that was published in 2016, they studied the inadvertent intrathecal injection and best practice management. What we can do if we injected by mistake a drug into the intrathecal space, or by mistake we injected a wrong dose into the intrathecal space. Besides the supportive therapy and besides the antidotes, they describe the CSF lavage. If we injected by mistake a large dose of morphine or any other drugs into the intrathecal space, we can aspirate CSF through needle inserted in the lumbar spine or through catheter inserted into the intrathecal space, and we can slowly aspirate 10 to 20 ml of CSF and replace this volume with 10 to 20 ml of normal saline, and the maximum volume that can be aspirated according to this article is 40 ml, but they reported a study that they aspirated 75 ml of CSF volume safely. This article was published in 2010 in Anesthesiology journal about the incidence, reversal, prevention of opioid-released respiratory depression. And according to this article, naloxone, which is an antidote for the opioids, has a shorter half-life than morphine, because the half-life of naloxone is 33 minutes only. This means that if we will give naloxone to reverse the effect of morphine, after about half an hour, patient will regain respiratory depression and decrease the or over sedation after half an hour of the injection of naloxone, because naloxone effect will fade while the morphine will be still acting. But they mentioned that this is commonly not seen in the clinical practice, because opioid concentration are often just above the threshold for respiratory depression. So we don't need to maintain naloxone all over the duration of morphine. We need to give a few boluses of naloxone or naloxone infusion until the threshold of the morphine go less than the threshold that produces respiratory depression. And they mentioned that respiratory depression occurs at a higher receptor occupancy than the degree of analgesia. So we can reverse the respiratory depression, but the analgesia will remain, although we are giving naloxone to these patients. Naloxone itself is not without risks. If we will inject a large dose of naloxone in these patients to reverse the effect of respiratory depression of morphine, if we will give the naloxone in large doses or rapid intravenous injection, this will lead to sympathetic overactivity and peripheral vasoconstriction, hypertension, arrhythmias, tachycardia, and shift of the blood from the systemic circulation to the pulmonary circulation, and patient may develop pulmonary edema or heart failure. So we have to inject naloxone slowly IV, and we have to start with small dose and titrate until we get the desired effect. If we will inject naloxone slowly and titrate according to the desired effect, this will lead to safe practice of using naloxone, and we will avoid all these risks. In 2016, both ASA and ASRA published their practice guidelines for prevention, detection, and management of respiratory depression associated with neuroaxial opioid administration. By neuroaxial opioid, we mean either intrathecal or epidural. And they recommended that before giving neuroaxial opioid, we have to identify those patients who are at increased risk to develop respiratory depression. As we mentioned before, elderly patients, those with a lot of comorbidities, obese patients, patients with obstructive sleep apnea, these are the patients who are at increased risk to develop respiratory depression. So if we will give intrathecal or epidural morphine, we have to arrange for more intensive observation and monitoring during the first 24 hours after injection of the intrathecal morphine. About the doses, they couldn't recommend a safe dose. They mentioned that we have to use the lowest effective dose. It has to be the lowest, and in the same time, it has to be effective, because if we will give a low dose that is not effective, and patient will suffer of pain in the post-operative period, and we added more systemic opioids, the combination of systemic opioids in addition to the intrathecal morphine will lead to more and more respiratory depression and more instances of the side effects of opioids. And they mentioned that if we will combine parenteral opioids or sedative with intrathecal morphine, we have to be careful, and we have to monitor the patient and observe the patient more intensively in the first 24 hours after injection of the intrathecal morphine. And according to the AS and ASRA guidelines, any patient who will receive intrathecal morphine, we have to monitor this patient for the following 24 hours after injection. Monitoring and observation of respiratory depression has to be done every hour for the first 12 hours and every 2 hours for the next 24 hours. After 24 hours, we will assess the patient. We can shift him to the ward or not. If the patient will develop respiratory depression, we have to be ready. Patient has to have a secured IV line. Oxygen has to be ready. We may use oxygen therapy if saturation is low. If the saturation is not low, we don't have to use oxygen. And we have to be ready with the naloxone, which is the antidote. And we have to be ready with non-invasive or invasive ventilation if the patient will need to support the ventilation in cases that naloxone will not reverse the respiratory depression. The other side effects of intrathecal morphine includes nausea, vomiting, urine retention, and pruritus, as we said. This study that was published in Anesthesiology in 2015, they examined the use of ondansetron in those patients who received 200 mic intrathecal morphine for cesarean section. And they found that if we will give the patient 4 milligram ondansetron, the incidence of pruritus will decrease from 88% to 16%. So those patients who didn't receive ondansetron, the incidence of pruritus was very high. But when other patients who received 4 milligram ondansetron, the incidence dropped to only 16%. Also, the incidence of nausea and vomiting in patients who didn't receive ondansetron was 56%. And in those patients who received ondansetron, the incidence dropped to 8%. This is another systemic review on naloxone, and it was published in 2016, and it included 1,129 patients, and they assessed the naloxone for treatment and prevention of the side effects of intrathecal morphine. And they found that small dose of naloxone, which is a mixed agonist-antagonist, small dose of naloxone, 2.5 to 5 milligram, it is the most effective treatment for pruritus, and it is more effective than any other pharmacological agents according to this study. And also this naloxone reduced the incidence of post-operative nausea and vomiting, and reduced the incidence of respiratory depression, and it didn't affect the analgesic effect of the intrathecal morphine. Another study that was published in Anesthesiology in 2019, they assessed the metoclopramide and propofol to prevent the side effects of intrathecal morphine. And this study included 360 patients undergoing cesarean section. And they found that for the prevention of post-operative nausea and vomiting, both morphine and propofol were adequately effective. These are the percentage of patients free of post-operative nausea and vomiting in the metoclopramide group who received 10 milligram metoclopramide 10 to 15 minutes before the end of surgery. And these are the percentage of the patients who are free of nausea and vomiting in the propofol group who received 0.5 milligram per kg propofol 10 to 15 mic before the end of surgery. And for the pruritus, propofol was very effective in prevention of pruritus. So these are the incidents of patients who are free from pruritus who received 0.5 milligram propofol in these cases. This form, we are using it in our hospital for any patient who we will give intrathecal morphine for him. And we endorse this form to the HDU or the ICU during endorsement of patient to them. This form is for intrathecal morphine. And in this form, we record all the analgesic given to the patient intraoperatively, either non-steroidal or opioid analgesia, and the recommended post-operative analgesia in the post-operative period. We recommend the dose, or we record the dose of intrathecal morphine given and the time. We recommend how to monitor and observe these patients in the first 24 hours for sedation, for respiratory rate, and we recommend them to be ready with the naloxone and the dose of naloxone needed if the patient develops respiratory depression, and when to call the anesthesiologist on call who is in charge for acute pain services, and also how to manage post-operative nausea and vomiting and pruritus. So I recommend if you will use intrathecal morphine, you have to have an endorsement form like this one with all the recommendations of observation, prevention, and treatment of the side effects of the intrathecal morphine. At the end of this talk, we will go for the take-home message. And we have to know that intrathecal preservative-free morphine is an effective analgesic to be used in the perioperative setting. It reduces the requirement for post-operative opioids. It is a simple, fast, has low failure rate and low instance of technical complications. If compared to the thoracic epidural, intrathecal morphine may be as equally effective in pain relief in the first 24 hours as the thoracic epidural analgesia. It does not produce hypotension observed in thoracic epidural, and it may decrease the hospital length of stay according to what was proved by many studies, and it decreases the pulmonary complication and it fastens the recovery after surgery. Intrathecal morphine is contraindicated in a day case surgery. Respiratory depression is the most feared complication after intrathecal morphine. If we decide to use intrathecal morphine, we have to identify those patients at increased risk to develop respiratory depression. We have to use the lowest dose, but the effective dose of intrathecal morphine. We have to prepare for appropriate post-operative monitoring and observation of these patients. Pruritus is the most common side effect, and it is the most annoying to the patient. Naloxone, ondansetron, subhypnotic doses of propofol and naltrexone are all effective methods to prevent and to treat the side effects of intrathecal morphine. And thank you for attendance.
Okay, thank you so much, Dr. Mohammed. And we start with some question from Muhammad Ali is asking, what I don't know, you are working in Saudi Arabia. Is preservative-free morphine present in Egypt? Dr. Safar?
I don't know.
Oh, no, خلاص, okay. No, Muhammad Ali, okay. Second question from Wissam, intrathecal morphine in uses in morbid obese patient. What do you think?
Yeah, it can be an easier alternative to do intrathecal injection in morbid obese patients than to do thoracic epidural, because thoracic epidural will be technically more difficult in morbid obese patients. But anyway, morbid obese patients are at increased risk to develop respiratory depression. So if we will use the intrathecal morphine in morbid obese patients, we have to be ready with the adequate monitoring and observation of these patients in the post-operative period for the next 24 hours, as we said, after injection of the intrathecal morphine.
We have interested questions from the admin, Mohamed Abdel Shafi. How to manage analgesia after you give naloxone, Mohammed?
As we said, we are titrating the dose of naloxone according to the response. As we said, we are giving small doses of naloxone to reverse the oversedation and to reverse the respiratory depression. But this will not reverse the analgesic effect. So we are giving small boluses of naloxone, maybe 40 mic by 40 mic, and we are observing the ventilation of the patient and the sedation. When the patient is getting the desired effect, ventilation is okay and sedation is decreased, we will stop giving naloxone. And at this stage, still there is an adequate level of morphine occupying mu receptors and producing analgesia. So the technique is that we are reversing the respiratory depression, but at the level that does not reverse the analgesic effect of intrathecal morphine.
All right. Another question from Mohamed Ahmed, not from you. How we can use the lowest dose of intrathecal morphine? What is the smallest dose should we use?
According to the procedure, and there was 2 slides with guide for the dose recommended for each procedure. In the presentation, there were 2 slides, one from the World Federation of Societies of Anesthesiologists with the recommended doses according to every procedure, and the other one from a review article published in Anesthesia and Pain Medicine. And according to these guides, we can use these guides to give the lowest effective dose of analgesia for every procedure.
Right. Another question from Hani Abdel Jalil about the best way to prepare and administer the correct dose of intrathecal morphine. I think he is talking about the aseptic technique or something like that. What is the best way to prepare and to give the correct dose?
Correct dose, we will calculate the dose and give according to the guides. Best way is that we will follow all the precaution for intrathecal injection, from sterilization and observing complete aseptic technique. And we have to use intrathecal morphine, preservative-free morphine that is manufactured for intrathecal injection, because this morphine is sterile and it is preservative-free. Does not contain any preservatives that can lead to chemical meningitis or neuritis.
Yeah. I may add, you can use insulin syringe to get the correct dose exactly. What do you think?
Yes, because the intrathecal morphine that we have in our hospital, it is 10 milligram per ml. So we have to use 500 mic, which is very small volume from this 10 milligram per ml.
All right. Okay. Another question from Amr Ali about asking the level of post-operative monitoring, but I think you already answered this, but you may reply it in short as well.
We are monitoring the patients to detect those who will develop respiratory depression. And as we said, there is no agreement for the best indicator for the respiratory depression after intrathecal morphine or any other opioids. Some studies depend on the respiratory rate, and they put a limit of 12. If the respiratory rate is 12 or less, this means that the patient has respiratory depression. Other studies put a limit of 10. Other studies put a limit of 8. There is no agreement between the studies about the limit of respiratory depression or respiratory rate that indicates that the patient has respiratory depression. But the best way is to use many factors: respiratory rate, over-sedation, and arterial blood gases to detect the respiratory depression. And according to the ASA and ASRA recommendation, we have to assess patients every hour for the 12 hours following injection of the intrathecal morphine, and every 2 hours after that until we finish 24 hours after injection of the intrathecal morphine.
Okay. Another question from Mohamed Ahmed again about the naloxone. Is it effective in the treatment of itching and pruritus?
Yeah. Naloxone, ondansetron, and nalbuphine all were used, and propofol all were used to prevent and treat the pruritus induced by intrathecal morphine.
All right. A question from Mito. I don't know who is Mito, but anyway, he's asking about the ceiling dose of intrathecal morphine. I didn't understand ceiling dose. Yani he need a maximum dose or what? I didn't understand the question well.
I may understand this by, I think he means that what is the dose behind which there will not be more analgesia produced by intrathecal morphine. We don't know. We don't know the ceiling dose, but we have limits recommended. Some schools say that 300 mic, we don't have to exceed 300 mic to avoid respiratory depression. And other schools said that up to 1,000 mic will not increase the instance of respiratory depression produced by intrathecal morphine.
Okay. From Wissam about the intrathecal nalbuphine, is it equal analgesic doses to morphine? Is it used nalbuphine intrathecal, Mohammed?
Yes. I don't know. I don't know.
Nalbuphine. I have no experience about that. Yeah.
No, we have
used it.
Yes,
nalbuphine?
Yes. We have about 2 to 3 master theses about it.
And you have it preserved free, Dr. Safa?
Yes. No.
Okay, yeah. I have no idea. Yeah, okay.
No, I have to. Okay. And lower abdominal surgeries and hernias, we have 2 master theses or 3.
A very complicated questions from Mahmoud Al-Abd, the technique of CSF lavage.
Oh. Very good.
It can be done by spinal needle or epidural catheters introduced into the interthecal space. And we
don't need manometer, Dr. Mohamed, بعد إذن حضرتك. We don't need manometer to about the intracranial tension while withdrawing this amount of CSF.
According to the recommendations that we have to aspirate slowly and to replace with normal saline. We will not aspirate and leave the CSF tension low. We will aspirate and replace with normal saline. Aspiration has to be slowly, and usually it's done by the patient.
I'm sorry.
1 to 1.
1 to 1? Okay.
Yes. If we will aspirate 10 to 20 ml, we will replace with 10 to 20 ml of normal saline, and the patient has to be in the lateral position, not in the sitting position.
Okay.
All right. Dr. Farida Azmi is telling you many thanks, Mohammed, for your lecture.
Thank you.
At your hospital, do you send all patients with intrathecal morphine or diamorphine to high dependency unit or ICU? All the patients should be in high dependency, or some patient can stay in normal ward?
Most of our patients are sent to the ICU or HDU after using intrathecal morphine. Myself, I do not use intrathecal morphine if the patient will go directly to the ward.
All right, okay. Yes, a question
This may be this may be the recommendation anywhere in the hospital that fulfill the criteria for monitoring and observation of the patient according to the guidelines. We can send the patient to it, but for safety issue and maybe for medical legal issue also, I do not send the patient to the ward after intrathecal morphine. And I do not use intrathecal morphine except in patients who are planned from the beginning that they will go to the ICU or HDU.
There is a comment from Dr. Asma about morphine-rich gray matter more than white matter. That's why the distribution and delayed action. That's correct?
Yes, because the mu receptors in the spinal cord is concentrated in the gray matter.
All right, okay. A question from Dr. Abdeldaim. Dr. Abdeldaim is asking about the time of initiation of patient-controlled analgesia after the intrathecal morphine. Can we start PCA, patient-controlled analgesia, after intrathecal morphine?
Yes, we can start it. We can start it, and a lot of the studies that we explored in this and mentioned in this presentation, the technique was intrathecal morphine plus patient-controlled analgesia. But according to the guidelines, we have to be cautious if we will give opioids concomitantly with intrathecal morphine. So we have to, if we will prescribe PCA, we have to decrease the dose and we have to increase the lockout time.
All right. There is some question from Mohamed Mohsen. You mentioned that morphine can reduce the fluid requirement, correct?
Yes, I mentioned that those patients who received intrathecal morphine compared to those who received thoracic epidural, the fluid requirements was less because thoracic epidural produced sympathectomy and vasodilation and hypotension. So to treat this hypotension and sympathectomy, we have to give more fluids. So the total fluid requirement for patients who received IT morphine was less than those who received thoracic epidural analgesia. And in some procedures like hepatopancreatic biliary surgery, this is of vital importance because the more fluids we will give to these patients, the more surgical complication at the site of anastomosis and the incidence of leakage from the anastomotic site will be more. So it is an advantage that we
Dr. Safa wants to tell something. Dr. Safa.
Yes, I will comment after Prof Mohamed. Really, it's a forward step. I considered it after you, Dr. Mohamed, is a forward step that intrathecal morphine after hepatobiliary surgery could be a forward step if we diminish the post-operative fluid management because diminishing the tissue edema, the edema at the site of anastomosis and early return to oral feeding. So I suppose it's a forward step to have ERAS after hepatobiliary surgery.
Yes, and now intrathecal morphine is included in many ERAS protocols for hepatectomy and hepatobiliary surgery.
Yes, I suppose.
Yeah. Dr. Ibrahim is asking about the record of this lecture, Dr. Safa, when you can provide it for them.
Okay. Tomorrow early in the morning will be on our group.
All right. So maybe my comment, I can summarize some point, Mohammed, if you allowed me. First,
Yes, of course.
intrathecal morphine can replace the epidural morphine for 24 hours. So just one shot, no need to put epidural and to follow up it for 24 hours. Correct? This is number one. Number
Yes.
two, maybe about the post-operative monitoring. You mentioned that CO2 may be normal and or the patient respiratory rate saturation may be is normal and CO2 is high. So do you recommend the CO2 monitoring? There is some new face mask or nasal cannula. You can introduce capnography to this. What do you think?
Yes, of course. Yes, of course. Yeah.
All right. The most common
The
complication, as you
monitoring-
mentioned, the post-operative nausea, vomiting, pruritus, respiratory depression, and what else? You mentioned something before.
Urine retention, but we don't know the
Urine retention. Urine retention. Okay. So, but all can be treated and not distressing too much for our patient.
Yeah, all are
Or what do you
preventable,
think?
and all are preventable and under control. It may be easier to control these complications than controlling the complications produced by epidural analgesia, because patients who we cannot use, for example, vasopressors in the world to control the hypotension from the epidural analgesia.
Yeah.
So it was mentioned in one study that the complication produced by intrathecal morphine was easier to control than the complications due to the thoracic epidural.
All right. Any difference in the side effect between different type of opioid if I use the intrathecal fentanyl or fentanyl or nalophene or morphine? Any difference in the incidence or side effects?
I don't know the incidence. Side effects may be the same, but the timing will differ, because they said that when we use intrathecal lipophilic opioid like fentanyl, the level in the systemic circulation is higher than the level in the CSF, and the onset is more rapid, and the duration is shorter, because this fentanyl will be cleared from the site of injection more rapidly than when we use hydrophilic opioid like morphine.
So morphine will be higher side effect because longer acting.
Morphine we will suffer from the side effects because most of the side effects produced by intrathecal fentanyl will be cleared during the operations. We are injecting 20 micro fentanyl in the intrathecal space, and patient will remain with us for 2-3 hours inside the OR. So post-operatively, patient may not suffer from the side effects because most of the fentanyl was cleared.
All right. Okay. For me, it is all done. Thank you so much. Dr. Safa, comment.
Yes. Thank you. Dr. Mohamed, please, if I have comorbidity with intrathecal, even single shot morphine, like obesity, hypothyroidism, and elderly patient, I would transfer him from the start to ICU unit after a single shot. Okay?
Yes, yes, of course. Any patient
comorbidity,
yes,
obesity, hypothyroidism, old age. Yes. Okay. Yes. What about you mentioned my great prof that any case given even single shot intrathecal morphine should be administered to high dependency unit or ICU. What about the obstetric patient? How can I do that?
I didn't mention that this is the recommendation, but I mentioned that for me, what I am doing is I don't use intrathecal morphine except if there is a plan to send the patient to the ICU or HDU.
Okay.
This will be according to the level of care in the ward. If the level of care of the ward can deal with these patients, they have the facilities and they have adequate nurse to patient ratio. So this patient can be treated in the ward. And most of the CS patients receive a dose of intrathecal morphine between 100 to 200 mic. And usually it was these patients will be sent to the ward, not to the ICU or HDU.
Please, Dr. Mohamed, what about the breastfeeding and the single shot intrathecal morphine? Something? Some studies about
I couldn't find an answer for this question, and I couldn't find studies that used intrathecal morphine for labor analgesia.
Yes.
Except maybe one study published in Ain Shams Anesthesia Journal, and it was done in India, and another study that was done in Asyut University. But there is no adequate evidence to use this in labor analgesia, maybe because we will give the intrathecal morphine and the patient will remain for many hours until she will deliver. And at the time of the delivery and passage of the baby may suffer from respiratory depression from this intrathecal morphine.
Okay. Yes. Another question, please. If we have another additives like dexmedetomidine, clonidine, tramadol, etc., even systemic, or augment the respiratory depression of intrathecal morphine, if we have systemically?
They said that sedatives, hypnotics, and systemic opioids will augment, and even magnesium sulfate will augment the respiratory depression produced by intrathecal morphine. But he didn't mention that dexmedetomidine, if used systematically, will increase the respiratory depression incidence of intrathecal morphine.
Okay. I just revised that ondansetron will inhibit shivering, hypotension, pruritus, nausea, and vomiting after single shot intrathecal morphine. Okay.
I don't know about shivering.
Yes, I have a study. I have read a paper like that.
Yeah, this is a new knowledge, new information for me. Okay. But what I know, it will prevent and decrease the incidence of the nausea and vomiting and
nausea, vomiting, and pruritus, and shivering and hypotension also.
Okay.
Dr. Safa, there is a comment from Yasser Reda. Can we?
Yes,
Yasser, go ahead.
Of course.
Thank you, Dr. Yasser. Thank you, Dr. Mohamed. Thank you, Dr. Safa. But I'm just not engaged in your discussion, but because this is my area of interest about pain and analgesia and narcotics. I just wanted to ask
Open
Dr.
your
Mohamed.
camera, Dr. Yasser. تفضل. Open your camera. Mohamed Abdel open the camera of Dr. Yasser. Prof Yasser Reda. Mohamed Abdel.
It's okay, no problem. It's okay.
No, you can join us, please.
Because this is not an acceptable.
Dr. Yasser, you are the main host. دكتور محمد دكتور محمد دكتور ياسر حد فيكم هيفتح لانه حضراتكم المين هوست.
It's okay, no problem. It's okay.
Okay.
I don't like to waste your time, but it's okay until they open. First of all, just I want to ask Dr. Mohamed about, like we know about Beresdex, for example. If you use the dose in the book in our patient in Saudi Arabia, in Arabia, or just in Qatar, it get an horrible side effect because I think we had a different patient. So I want to ask you about what is the dose used for your intrathecal morphine, because you speak about bizarre doses from 100 mic to 500. What is the dose used in your practice?
Usually I'm using a dose of 7 to 10 mic in donor hepatectomy patients, because these patients are usually they are young and they are healthy patients. So I use a dose of 7 to 10 mic in these patients. Sometimes I need a small dose of naloxone during waking up these patients with the reversal of their muscle relaxant. I may need small dose of naloxone to reverse the effect of their respiratory depression and over sedation. But all patients who I gave naloxone during the extubation of these patients, they didn't need any naloxone in the post-operative period in the ICU for the following 24 hours. And with this dose, patient is nearly pain-free until the next morning after surgery. And a lot of these patients started to receive oral feeding and started to ambulate a few hours after surgery.
Again, so I need a few words about extended release the morphine, because we need a few words about it, because first time for me, I hear about injection extended release morphine.
I don't have a lot of information about it because it is not available in our hospital, and I think it is not available in Saudi Arabia. It is a kind of liposomal morphine, like the liposomal bupivacaine. Its onset is delayed and its duration is prolonged. In the studies, when they compared the extended release epidural morphine to intrathecal morphine, the duration of analgesia produced by the extended release of epidural morphine existed for 36 hours after injection of the extended release single shot epidural morphine. And in one study, it was given in a dose of 150 mic per kg in the scoliosis surgery. And in another study, it was given in a dose of 7.5 milligram in cesarean, in gynecological cancer surgery.
Last question, and sorry for delay.
No,
you know that we are in the era of opioid-free anesthesia or opioid-less anesthesia. I know in some cases it's very important to use opioid, but do you have show any study about comparative study between intrathecal morphine and regional anesthesia for any technique, and what is more better and what is more bad for using narcotics? Thank you very much.
I don't have a study comparing only intrathecal morphine to regional anesthesia or nerve block. I don't have a study comparing these two techniques, but I think still we have a recommendation that we have to use multimodal analgesia. For post-operative major surgeries. If we will use intrathecal morphine, we have to add in the multimodal analgesia non-opioid analgesics, and we have to utilize all the local anesthesia techniques, either regional block like tap block or wound catheter infiltration. Or local anesthetic infiltration of the wound, or wound catheter continuous infusion of local anesthesia. This all will delay the onset of pain post-operatively, will decrease the need for systemic opioid analgesics, and will increase the satisfaction of the patient.
Thank you, Dr. Mohamed. Thank you, Dr. Yasser. Thank you, Dr.
Welcome.
Thank you very much.
Welcome.
Thank you.
Dr. Yasser, بعد إذن حضرتك. Yes. Just 2 or 3 questions only. دكتور محمد، يعني أنا طبعا بسأل عشان المحاضرة كانت رائعة بصراحة، فمعلش حضرتك
الله يخليك.
الله يخليك. حقك عليا.
اتفضلي.
حقك عليا والله.
لا ابدا
والله. دكتور محمد، بعد إذن حضرتك، التايمينج of naloxone, is it related to the severity of respiratory depression, or it is just a time lag between the injection? Sometimes respiratory depression starts about 6 hours to 24 hours, as you said. If the start of infusion of naloxone is a time dependent or symptoms dependent?
No, it is most of the studies recommend to use the naloxone if the patient developed over-sedation or respiratory depression. And few studies recommended to maintain the patient on a low dose naloxone in the first few hours after injection of the intrathecal morphine.
Routine?
And the respiratory depression.
As a routine?
Some studies recommend it like that, but most of the studies recommend it to be in our hand and don't use it except if the patient is over-sedated or developed respiratory depression.
Yes, sir. What about Nalophene as a treatment of respiratory depression and after intrathecal morphine if I don't have naloxone? Sometimes we don't find the naloxone. If Nalophene can replace it?
Yes, studies that systemic reviews that were included more than 1,100 patients. They used Nalophene to treat and prevent the side effects of intrathecal morphine. And they mentioned that the Nalophene in a small dose, 2.5 to 5 milligram, because Nalophene is a mixed agonist-antagonist, decreased also the pruritus, the nausea and vomiting, and the incidence of respiratory depression produced by the intrathecal morphine.
Yes, my last point. I'm sorry.
Yeah, welcome.
As regard the post-operative cognitive dysfunction, patient who vulnerable to that, the elderly patient or that have the history, Alzheimer or any other CNS, or the group of patients that called drug dependency syndrome. If I can give them intrathecal morphine safely to make the post-operative analgesia opioid-free, systemic opioid free, intrathecal morphine can replace that, in such a group of patients?
I couldn't find any source to answer this question. I don't know if it can be safely given to such group of patients. But as we know that elderly patients are at increased risk to develop respiratory depression, but it is not contraindicated. We just have to prepare for adequate observation and monitoring of these patients. If we will give intrathecal morphine and the patient will be alone in the ICU post-operatively, I think this will increase the post-operative cognitive dysfunction. But if we will give intrathecal morphine and we can monitor the patient in the ward while he is between his family members are with him, it may decrease the instance of post-operative cognitive dysfunction.
Million thanks, Dr. Mohamed. I'm very sorry. I'm very sorry.
No, thank you, Doctor. Thank you.
Okay. Thank you, everybody. Any more comment? Can we go home, خلاص? Okay, thank you.
Thank you.
Thank you.
Thank you, Dr. Mohamed. Thank you, Dr. Yasser. Thank you for all our attendees. Thank you. Thank you all. Thank you.
Thank you.
شكرا لحضرتك. شكرا. دكتور محمد حضرتك هتقفل الميتنج، حضرتك الهوست.
اوكي.
اتفضل. مع السلامه. مع السلامه. وعليكم السلام ورحمه الله وبركاته. وعليكم السلام ورحمه الله وبركاته.